This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
go. Lade, that's right, isn't it? Cool. Good morning, everyone, and can I welcome everyone to the Police and Crime Committee meeting. This morning we will be holding a discussion on policing and mental health and neurodiversity. Please make sure that your electronic devices are switched to silent mode to avoid any interruptions. And can I now ask our clerk, Lauren Harvey, if any apologies have been received?
Thank you, Chair. We've not received any apologies for absence this morning.
Thank you. And can I ask the committee to note the recommendations set out at item 2 and ask if members have any other interests to declare? Noted. Thank you. And can we confirm the minutes of the meeting held on the 10th of January 2024 to be signed by me as a correct record? And can we note the outstanding actions arising from previous meetings of the committee? Thank you. So we now move to our main item of business, and I would like to welcome all our guests. So we have Dr. Lade Smith, CBE, President of the Royal College of Psychiatrists. We have Dr. Sarah Hughes, who is Chief Executive of Mind. We will be joined by Lynette Charles, who is Chair of Mind in London. We have Commander Kevin Southworth, Head of Public Protection at the MPS. We have Detective Superintendent Alastair Vanner, who is the lead responsible officer for mental health in the MPS. We have Alison Blakely, Director of Clinical Assessment and Pathways with the London Ambulance Service. We have Daniel Elkeles, the Chief Executive of the London Ambulance Service. And we have Martin Machray, MBE, who is the Executive Director of Performance with NHS England. And it is brilliant to have such a wide-ranging panel, because our discussion about right care, right person is absolutely dependent on that working together process. So we're really looking forward to hearing from you all. I just, before we start, want to mention that some listeners may find topics that we discussed during the meeting this morning triggering, and if so, help is available 24 hours a day through agencies such as the Samaritans, and they can be called by dialing 116 123. So we will now move on to the actual questions. So I'm going to start with the Metropolitan Police Service. And I think actually this is something all the way through the meeting, because we've got more than one person from several organisations. We will direct our questions to a particular organisation, and you possibly need to just juggle between you which of you is best able to answer the question. So we've got police, ambulance and mind. Obviously Martin and Lade are kind of questions will be directed to you sort of directly. So for the Met, how would you describe the demand responding to mental health incidents is placing on the Met, and in what ways this has changed over the last 5 years?
I'll lead off, Chair, if I may. My colleague, Detective Superintendent Vanner, is actually our mental health lead responsible officer, so you may be able to add more detail if I miss anything. It's always good to have an expert sat behind you, isn't it? But from my perspective, I took up post as Commander of Public Protection, as the committee will probably remember, about 2 years ago now. And we certainly recognise that the scale of how we supported people in mental health crisis in policing was really putting a huge strain on our front line, and more importantly, not always resulting in the right outcome for those people who we were trying to help. Because ultimately, whilst our officers and staff will always do their best for the public and have some insight through the training we provide into mental health illness and also to neurodiversity challenges and so on and so forth, the reality of it is that we're not clinical experts, and we're not going to pretend to be. And it's colleagues to my left, from the ambulance service and from the NHS are infinitely better placed to deal with people in mental health crisis than we are. And that goes often to the heart, I think, of where right care, right person, I'm sure when we come on to it, is set, hence the title. But in terms of that demand point, it was really quite pronounced most in the number of people that we as a service were detaining under Section 136 of the Mental Health Act. Now, there are other facets. There's Section 135, where we execute warrants in support of people who need to be brought in for their own care. But Section 136 is, as colleagues on the committee will know, is the power by which police officers can effectively detain, arrest, if you want to use that term, a member of the public for their own safety because there's a serious risk to life in a sort of public situation. It is a necessary power, and sadly probably always will be, because there will always be times when our officers must detain someone for their own safety. But there's no doubt that, through no fault of their own, our officers too often were finding themselves in situations where they felt they had no alternative but to arrest and detain under Section 136. This was running at some points up to as many as 700 detentions per month, and that, I'll call it over 136ing, if you like, of too many people, undoubtedly put significant additional strain into our colleagues to my left, so the ambulance service and particularly to emergency departments and the National Health Service, because whilst, of course, we would prefer to take people where we can to health-based places of safety if they're detained under that power, all too often our officers were finding themselves at the nearest emergency department where they, because of the law in place, would need to stay with the individual detained for sometimes as much as 12 to 14 hours at a time with 2 PCs, someone detained under arrest effectively, sometimes perhaps in handcuffs if they've been particularly violent. That's not a place where we want those members of the public to be. It's not a place where our officers wanted to be, and it's certainly, I'm sure, not where many of our colleagues in the health service would prefer any of us to be. So that demand, as it stood at that time, going back 2 years, was a real challenge for us all, and right care, right person has been absolutely fundamental in shifting that paradigm significantly. So without going into too much detail in too early in what could be quite a lengthy committee, the good news, I think, if I can cleave to that from the public and from this committee's point of view, is those numbers have come down massively. So the last 3 months, we've been averaging less than 400 Section 136 detentions a month by Met Police officers, which is a huge reduction on what was 700. The gains in that, of course, are really pronounced in that every time you have 2 PCs who are off the road, detaining someone in such a situation like that, they're no longer available to take the immediate response calls that we need them to take. They're no longer available to police the demonstrations we need them to police. And more importantly, for members of the public who are affected by serious mental health, they're in a situation where they're being detained and arrested effectively by 2 police officers who are not necessarily best placed to care for them. So that reduction has been, I think, one of the best successes I've seen in recent times in policing, and a huge debt of thanks to our colleagues to the left from LAS and NHS, but also from other partner agencies as well, in helping us to deliver that, because it has given us undoubtedly tens of thousands of hours of PC time back into police service, and prevented, as again, more importantly than our demand, more importantly than that, it has meant that we have detained roughly 200 to 300 less people under arrest for what is effectively being in mental health crisis in these last few months, which I hope is a good news story on every level. But that's probably enough from me, just as a headline. My colleagues may have more to offer, and if that's helpful, Chair.
That's a very, very helpful introduction. And so you say tens of thousands of hours back to the police. Is that something? Are you tracking that? You are. Yeah. Thank you. So, in what ways does the Met support officers to identify people with mental health conditions or who are neurodivergent, and what opportunities are there for officers to feed back and learn from their experiences?
Well, in individual instances where something has gone particularly critically challenging, there will always be a debrief process in terms of reverse order, organisational learning from instances where things have gone wrong. So we do have an effective organisational learning process within the Met for, dare I say, critical incidents where something bad has happened. I wouldn't say we debrief in every single instance, because obviously the numbers are very, very high, so we won't be able to always do a debrief in every situation where we've had some, but where there is learning, we definitely will. I think moving back through those points, though, in terms of the training, there's recruit entry-level training, which we give to all of our officers and staff around people with vulnerability, people suffering mental health illness, neurodiversity, just to try to raise that cultural competence, that awareness in our recruits. But I think perhaps more importantly, and impressively indeed, the work that Detective Superintendent Vanna and his mental health central team have been doing to raise awareness in frontline teams has been really important. And they've gone round to all frontline emergency response teams, for instance, to give briefings, literally every team in the Met Alley, I think, in fairness, which is a really impressive feat. We're rather a large organisation, but to brief them on not just what to do in these situations where we think someone might be at risk, but what the alternatives to Section 136 are. And that has included things such as creating an app where we mapped out all the mental health crisis cafes across the city so that our officers at least had some alternatives. Rather than thinking my only option here is to detain this person for their own safety, could we potentially get them to voluntarily attend a mental health crisis cafe? As you know, there's about 30 of those across the city. They're really valuable institutions. Some of them are reporting low footfall, and actually that's a travesty, because ultimately if we can redirect people in mental health crisis to those institutions, then obviously that's always going to be a better solution, I would suggest, as long as we do it in a safe and proportionate manner. So whether it's awareness of alternatives, whether it's upskilling in terms of training and cultural competence, we've tried to come at this from a number of different lenses. But again, I'll defer to Ali in case he's got anything to add on that, if I may, Chair.
Yeah, I think it's important to consider that prior to Right Care, Right Person, we'd worked extensively with my colleagues to the left to think about those alternatives to Section 136, but also the availability of the Section 136 hub, which is staffed by NHS staff, so that officers, when they come across someone in the street in mental health crisis, they're able to call that advice hub 24/7 and get clinical advice. And that is in the Mental Health Act legislation, that we should be getting clinical advice for every call that we go to. So prior to Right Care, Right Person coming in, we'd actually made significant difference in bringing down the number of people that we were detaining under Section 136 because of that training around alternatives. Is there a family member, a carer, a loved one that we can take that individual home to rather than taking them to an accident emergency? And then going into the Section 136 Advice Hub provided to the police by the NHS to get clinical advice around what is best for that individual.
When were those hubs first set up?
It actually the hub went live on the same day that Right Care, Right Person did.
Okay, so it's part of the Right Care, Right Person.
It's not actually part of it. It's something that we had in the planning for a very long time, over a couple of years. Martin may want to talk more.
Okay, yes, please do.
Thanks, Chair. The advice line and the hub were part of a broader agreement between local authorities, the GLA, the Health Service and other partners, including the Met Police, under something called the Mental Health Concordat, which was signed in May of last year. And it aimed to do a number of things, irrespective of Right Care, Right Person. We knew that Humberside were trialling it, but it was part of the challenge that we knew existed within the health service and within the public sector generally, where we saw a rise in people being detained under the Mental Health Act, under Section 136. We saw a rise in the number of admissions through an A&E department for people in mental health crisis. We saw long delays in those A&E departments as people tried to get into beds or into other therapy services, and we've seen a real challenge to the mental health services, the secondary mental health services within the city, where demand has risen for their services, and doctors and nurses across the city are facing every day a huge amount of pressure to treat the patients in front of them. So as part of that overall scene, we decided that we would start to address how to improve the alternatives to A&E, how we'd help the police have alternatives to use of 136. Though 136 we shouldn't think as a bad thing. It was set up as part of the Mental Health Act in 1983 for a real purpose. The problem is it's been overused over time because of the demand on services, not necessarily for the right thing for the right person. And also to challenge some of the, to work on some of the housing issues and the discharge issues that the health service has, as you might imagine. So as part of that overall concordat, which was led by the chair of South London and Maudsley, Sir Norman Lamb, we agreed that we would set up a clinical advice line to the police in the hope that they would use that clinical advice and learn, back to your previous question, about when would be most appropriate to use what sort of service and when. That happened to go live, as Alastair said, about the same time. I think it was the 31st of October it went live. Within 24 hours it went live. It has seen a remarkable change in behaviours. It isn't because of RCRP, it's because of the work we collectively saw was challenged, was needed to meet the challenges within London.
Thank you, that's really helpful context. So I just want to bring in Mind and also Dr. Smith. For both of you, you'll have to choose who goes first. Are there any areas relating to mental health that you think could be better understood by the police?
Thank you so much for the question. I think it's a really important one. And I think the context here is that policing and mental health has been a challenge for decades. This isn't new news. And indeed, the crisis care concordat that we led in 2013-14 laid bare some of these challenges in real time. And that's where many of the sanctuaries, the crisis cafes, the new crisis pathways were developed. And so we have been here before. I guess in terms of the question, are there issues in relation to mental health that the police don't understand? I mean, I think it's fair to say that they aren't the experts and they recognise that they're not the experts, which is why Right Care, Right Person has come about, I guess. What I would say is that whilst the police are not ideal for every situation, they are for some. And it's really important to acknowledge that we support the principles of Right Care, Right Person deeply, profoundly, especially because of the impact that policing can have on racialised communities, for instance, in Section 136. However, that said, it is striking that we go from 700 136s to 400 136s in such a short period of time. I do wonder where those additional 300 people have gone, because those needs don't disappear overnight. And I guess that is the deep and profound concern that we have. And so it's about, the police necessarily won't know what is a mental health issue or not until they get there and are able to assess the situation. So in that respect, that can be difficult. I think it's difficult in relation to assessing whether things are life and death. So if somebody's at risk of suicide, again, you won't know the risk until the person's in front of you. And so there's a bit of a gap between what we think the police should understand in relation to mental health and what is readily available for police officers on the ground. So that gap still exists. That gap is not going to be addressed by Right Care, Right Person. And whilst we agree with the principles, there are some grave concerns we have about the rollout and the unintended consequences of this important policy.
So that's the sort of unintended consequences is sort of who's tracking the 300 people that are no longer being dealt with.
It's not just
through
about
136, or that's one of the things.
That's one of the things, although of course we know at the moment the only data that's really been collected in relation to Right Care, Right Person is from the police perspective, not from the system perspective.
So from a health perspective, or a mental health perspective, one would want processes in place for tracking the outcomes for those people.
Indeed.
And who would that tracking job sit with?
Can I add?
Yes, please do.
Just to say that in addition to being president of the Royal College of Psychiatrists, I'm also a jobbing clinician. So I'm consultant psychiatrist at the South London and Wolsey NHS Foundation Trust, and I'm also the clinical director of the forensic services at SLAM, as it's known. And I am responsible for all the acute forensic admissions for South London. And the reason that's important is because as well as getting reports from, in fact, colleagues all over the country and mental health trusts all over the country, I also am aware of what's happening in South London, in particular what's happening with relation to the Met Police, the work that we do with the Met Police. So, as Sarah has said, there's no doubt at all that the idea of trying to reduce police input to when people are in mental health crisis is a good idea when it's done properly. The difficulty that we have is the way in which the right care, right person has been implemented. We know already, and I think Martin described some of the context, but I think you were, perhaps playing it down a little bit. The state of mental health services in the country, in particular in London, are parlous, actually. We have had chronic under-resourcing. We have terrible workforce shortages. And since the pandemic, as everyone knows, there's been a 20% increase in need and demand. And that's across the board, particularly in children and young people. That, unfortunately, and before the pandemic, actually, mental health services were actually meeting that need and demand despite everything and how hard it was. We were meeting that demand, and since the pandemic, it's gone up. That means that there aren't more people to do the work. And it also means that, unfortunately, our waiting lists are higher. And when people sit on waiting lists, they're much more likely to go into crisis. Yeah. So the context is that there are more people going into crisis. Unfortunately, that means that there will be more people who are either at home or in a public place who are so very unwell and unable to be safe that they need input. And the crisis concordat was excellent in terms of identifying ways in which mental health services, ambulance services, and the police could work together to provide a service to those people who may go into crisis. And it also very, excellently included the charities. So a lot of the mental health crisis cafes and those hubs are actually run by charities. And that was a really positive thing. The difficulty for us was then there was a sudden cliff edge announcement that things were going to suddenly change, and that even though we were working along with all the different agencies towards developing a gradually improving offer of mental health services, and we completely understand why there was a sudden, right, that's enough now, we can't do this anymore. And there's a simplistic idea that somehow if someone's has a mental health problem, that they're not going to need police input. And in fact, there's a whole branch of psychiatry which is about people who unfortunately develop mental health problems and then have become violent or have to have contact with the criminal justice system. And in fact, if you go to any prison, 70% of people in prison have a comorbid mental health problem. So we know that people with mental health problems may well offend. And there's a whole part of the Mental Health Act called the Part 3 of the Mental Health Act, which is about supporting people who fall foul of the criminal justice system. That's and 136s and 135s are part of that. We accept very much so that there's far too much use of 136s. What we are concerned about is that as a result of the messaging and the way in which right care, right person has been implemented, it's meant that even where there hasn't been all the work, the partnership work that takes some years actually, Bobby's on the beat, and perhaps more senior police officers as well have decided to take matters into their own hands. And actually, the understanding and the learning and the knowledge that they have to do that, I think, is limited. And it's of interest that we haven't had much contact with the police until recently, actually, about how we can support that. One of the main things that the Royal College of Psychiatrists do is to educate and train. And we educate and train at a very high senior level, including around the law, etc. But what we're hearing from, we've not really had any contact with the police about that, I'm afraid. And what we're hearing from our colleagues is that so for example, a 135 is when a police are called to support the conveyance of someone who has a mental health problem from their home to a place of safety. And the only people who have the powers to do that conveyance are the police. That, in order to do a 135, you will have repeatedly tried to see the person, you will have repeatedly tried to engage them. It takes a lot of work for an approved mental health professional. They have to go to court, sit in a magistrate's court all day to get a 135. And then what's happening more recently is that people are phoning the police and the police are telling us, no, we can't come because we're not doing mental health. Now, that's a mistake, but that's an indication that sometimes, unfortunately, on the ground, the police haven't got the knowledge that they need to be able to institute this programme properly.
Thank you. That's really, again, really useful grounding for this conversation that we're having this morning. I'm just going to bring in the London Ambulance Service at this point because you haven't had a chance to contribute just to the beginnings of what we think about right care, right person.
So the beginnings.
Oh, and actually, sorry, I meant to say, can you all move your microphones by the base slightly closer to you? And those of you sitting on the sides, if you direct them, because you're looking this way towards the committee, direct it so that you're speaking into it. That would be really helpful. We just had a message from the broadcast team. Go for it.
Hopefully I've just followed the instruction.
Perfect.
So our perspective is slightly different. So we believe we've worked really closely with the Metropolitan Police in the run-up to the implementation of our CRP. And the way we worked closely was we, with the police's agreement, put some of our clinicians into the police control room to actually find out who are all these people and what are their needs. And the Section 136 patients is actually quite a small volume of the total patients we're talking about. So an awful lot of the calls are people, imagine someone's been burgled and they're in distress and the police are thinking, need some health input into person who has been burgled. And that's clearly nothing like a Section 136 patient. So having listened with the police to lots and lots of the calls that their police handlers were taking, we agreed a script with the police call handlers, which is very quick, where the police call handler can identify, is the person, do they have a health need or not? So I think the police, based on that, are then able to say to a lot of the people they're talking to, you don't have a police need and you don't have a health need, so that's the end of the conversation. But all the people who have a health need, they then pass down through, we have a dedicated IT link from the police control to our control, and we're receiving between 200 and 250 referrals from the police a day. Nearly all of those people really are patients, and it is totally right that the police no longer send a police response to those people, but the NHS works out what is the right care. And so what we have assembled is a team of our clinicians to triage the calls that come from the police, and we then decide, is the person actually a patient for the 999 system or a patient for the 111 system? And nearly all of the people are actually patients for the 111 system, and then because we now operate 111 across the whole of London, in part, we can get it to the right 111 service and do the assessment. And nearly all of those patients, they come out the 111 assessment, and we can work out what is their health need, and we get a good response. Would you like to then explain the mental health part of the system?
Thank you so much. So Daniel's just explained what we did as a group at the launch of Right Care, Right Person. That enabled us to really risk assess patients as they arrive within our system. So when the calls arrive into the London Ambulance Service, as Daniel's just explained, we have clinicians who are able to undertake a triage of those patients. We also have some mental health specialists within that team that we employ directly, working within our control room. So that adds a level of mental health specialism within our control room also. We have a number of mental health pathways, some of which have just been mentioned by colleagues to my right. So we're able to refer patients electronically or via a clinician to a clinician conversation into existing mental health pathways right the way across London. But we also have some specialised responses that we can send physically if that patient needs a physical response. So across London, we have 6 mental health joint response cars, which are also mentioned within the mental health concordat. Those cars operate in each of the 5 ICBs, and then there is one additional car that works in the centre of London and can travel to any of those 5 ICB areas. And those cars are staffed by a mental health clinician and a paramedic, both of whom are employed by the London Ambulance Service to specifically provide this service. And they will attend patients who are in a crisis or patients who have directly called 999, come through to the London Ambulance Service with a mental health need. And since the launch of that service, the service has grown, but we've also seen the volume of patients who have been successfully referred into onward care at home or an onward pathway really increase. So at the start of the programme, when we were sending a double-crewed ambulance to the majority of these patients, we saw about 70% of those patients being conveyed into an emergency department. Now with the mental health joint response cars and this programme of work, it's about 20% of those patients being conveyed to an emergency department. And that risk assessment is undertaken by those joint clinicians. They have access to the patient's prior health records, including mental health notes, and therefore we're able to have a clinician-to-clinician conversation about the best next steps for those patients in live time.
Thank you. That's huge amounts of information about a new system. Sarah, did you want to just come back on that?
Yes. I mean, I think it's really, really helpful to hear all of this. And what I would say is that it is interesting because I think around in terms of who are the experts in this conversation around mental health. And again, with all due respect, I wouldn't consider the paramedics either to be experts in mental health. So it's really interesting that you all kind of made up this kind of process and these pathways without the engagement of expertise. And so I think that's really important to recognise. And if you were listening to this outside, you would think this is a perfect pathway. And I have to say that is not the experience on the ground one. And I think one of the things that we must also attend to is that right care, right person also applies to under 18s, although that there is a grave, again, difference of opinion between government departments on that, which we may come and draw on later on. But again, I just want to acknowledge that because I think that's a really important point.
Very briefly, because I'm wanting to move.
It's just to say that this is fantastic, actually, and we really welcome what's been done. But what you've described is how the police and the ambulance service actually were responding to people in distress that isn't mental illness. And I think this is about, and this goes to that thing of really understanding the difference. Everyone has mental health, obviously, but a few people unfortunately have mental illness. And actually my concern is that, it's number one, it's a great thing that people are thinking much more about their mental health and have been over the last few years. But the concern is that understanding about mental health has not translated into an understanding of mental illness. And what you just described to me is a wonderful example of how you've stopped dealing with complaints that are to do with people who have mental distress, who don't have mental illness. But I'm still concerned about how we manage people who actually have mental illness.
That has been. I'm actually going to bring in other members with questions at this point, but that has been very helpful to kind of show. Well, it just shows the complexity of this whole situation, the scale of it, and you know we've got a sense of how the police and the NHS are managing with very tight resources, and we've got a situation of huge amounts of need. So I'm going to move on to other questioners and bring in Assembly Member Hall.
It's been answered, Chair. It's been answered.
In which case I'm going to bring in Assembly Member Desai. And Assembly Member Desai, we have strayed into some of 4 and 5, but you go for it.
should be used to this by now. My first question is to the police, either Kevin, yourself, or your colleague. So studies show that almost all responding officers are exposed to traumatic events, and that about 1 in 5 police officers experience PTSD themselves. In a report, Baroness Casey found that response officers, and I quote, did not seem to routinely have access to mental health support, unquote. What kind of services are available to officers that are struggling mentally as a result of traumatic experiences from serving?
Thank you, Assembly Member Desai, and for your concern for our officers and staff as well. There are sort of 3 tiers really to how we try to support our officers and staff in any such situation. There's a more long-term offer around obviously occupational health support, and we can provide sessions of counselling for colleagues provided by an outsourced provider who've been subject to either traumatic incidents at work or perhaps suffering from long-term mental health illness or distress of some type. So that's a more diffuse offer that takes a little longer to deliver. It is available to our officers through our occupational health department, and which has been some time in formulation and well progressed now. Then there is more acute services, if you like. So if there's a particular critical incident, we have our trauma peer support service, which is a new initiative which has been rolled out in order to provide that immediate cathartic debrief process and counselling around an incident which may be particularly challenging for our officers and staff. Just the other day I visited one of our child abuse investigation teams where they'd had 2 sudden unexplained deaths in infancy to deal with in the same week, and of course it's extremely exacting emotionally for those who are involved in such instances, and to make sure they're aware of this sort of facility being available to them. I think honestly reflecting, if I may, the challenge we have sometimes is making sure we communicate effectively to our officers and staff that all of this is available to them, because it's not always as well known as we'd like it to be. And as part of the programme which I lead, which is the Strengthening Public Protection Programme, we're making sure that we have a whole work stream that dedicated to not just ensuring the provision is available, but their officers and staff know that it is there as well. And just as a sort of middle ground between the two, so the acute and the longer term, I feel I'm straying into medical terminology here. I should be careful, there's genuine experts around. But in that middle ground between the two, we also have been rolling out our TIP-T training, which is trauma-informed peer training, so that we have a sort of a self-regulating process within our teams where colleagues try to identify amongst themselves if a peer is under particular psychological pressure and can step in and intervene in that space. So those are the 3 sort of layers, if you like, from the slower term to the more acute, and with the TIP-T training, TIP-T, trauma-informed, in the middle. I hope that's helpful.
Yeah, thank you. So again, yourself, Kevin, or your colleague, the Met has been condemned for a culture of victim blaming. However, Baroness Casey found that victims who were neurodivergent or had mental health struggles were more likely to have their credibility challenged by officers. What is being done to ensure that neurodivergent victims aren't being discriminated against, and that offending officers are made aware of this and appropriate action taken if necessary?
Thank you. The suggestion of victim blaming is one that's been come to the fore during the recent HMIC inspection as well, as you'll know. And I think it's a very broad-ranging term. So in some areas, we've made great inroads into that. If you take, for instance, the Operation Soteria work, which I also lead on, which is about how we transform our approach to rape investigations, that's a particularly important area to get right, because we know that historically, too often, victims themselves have often felt that they have been the one under investigation rather than the suspect who the allegation is made against. So there's been significant inroads made there to make sure that we bust the rape myths, as the terminology has been used, I think, by the Law Commission, actually, as opposed to just by us in policing, to challenge some of those sad stereotypes that have been there in the past, that somehow people are responsible for what has happened to them, or worse still, are actually to blame. So in discrete areas of what we do, rape being an example, we've gone to great lengths and continue to do so to make sure that our officers and staff are culturally competent to acknowledge the existence of those stereotypes and make sure they don't fall prey to them. More broadly, in areas like neurodiversity, which of course is a far vaster landscape than the rape allegation area, where we have 9,000 offences a year. We're talking about entire communities who may suffer from neurodivergent issues. The challenge there is to make sure that our entry-level recruits are upskilled in that way. And as I mentioned just earlier in my evidence, there is an input to our recruits and officers when they come through the training school process to try to make sure that they are at least aware or sensitive to neurodiversity issues, so they understand the challenges that members of our community may face, and avoid that risk of somehow failing to understand them, or worse still, blaming them for the situation. So between, again, the acute and the long term, there are discrete areas where we're doing really surgical stuff like rape investigation. Very soon you'll see our long-awaited child first strategy, looking at how we make sure we raise our cultural competence and awareness of the challenges that children and young people face, many of whom will have neurodivergent conditions. And then there's the entry-level training we try to do to upskill our officers in broader awareness.
Thank you. Chair, my next two questions have been touched upon, so I will put them formally, but I will ask the panel to be very, very brief. And particularly this question is directed to the NHS, because I don't think you have the chance to comment on this. To what extent, Martin, do you believe that the police understand the demand mental health is placing upon them?
As you said, Assembly Member, I think we've partially covered that. There's a lot that we have to respect the various skills across the entire sector. The police are experts in policing, our clinicians are experts in mental health or mental illness, and our community sector are best at supporting communities and families. Part of the reason for our CRP coming into being, part of the reasons for the concordat, is because over time we get the balance wrong between who does what, and we try to self-correct or try to amend. And what you've been hearing today is how we get that. So the police have lots to learn. I've got lots to learn about how we support the police. And I think the key is in the partnership. Can I just say one other quick thing? We keep referring to RCRP as about mental health. RCRP is not about mental health. And I'm really concerned that we start to stigmatise people who have a mental illness and link it to RCRP. RCRP is about making sure that the people get the right care at the right time. And that care might be someone with dementia walking off my ward, which, in my clinical practice happen quite a lot, and we've talked about those things. So making sure that we get the right services to the right people is not just about someone who's got a label of mental illness.
And do you have anything to add to what you already said, Dr. Smith or Dr. Hughes? Or indeed, Lynette, because you've not spoken yet.
Just to add to what Martin said, actually, that it is about the right care to the right person at the right time. And that the main and just about that everybody thinks this is a good idea. It's the way in which it's been implemented, and I think we've already seen today that there are. It's interesting that it should be about partnership, but people haven't involved all the partners, all the stakeholders, and that unfortunately is something that happens with mental health care and mental illness all the time, where the people who really need to be involved are actually excluded because they're not thought about. It's often an afterthought. And I have to say that there is long-standing societal discrimination against people with mental illness, and we have to be mindful of that, and that is going to have an impact on the way any policy is implemented, because there are already unconscious biases at play.
Lynette?
Yeah, I just wanted to add to that I do appreciate that right care, right person is about health for everybody, but I think that when it comes to mental illness, we want to make sure that we get it right, because that has a bigger impact on our society, and we've seen that recently when we do not get it right for people with mental illness. So I do appreciate it's for everybody, but we've really got to get it right with mental illness.
Thank you. And my final question, very, very briefly, is to mind either Dr. Smith or yourself, Lynette, sorry, Dr. Hughes or Lynette, and yourself, Dr. Smith. So how would you describe the way the police respond to people with mental health needs? In one word, good, bad, room for improvement? And if there's room for improvement, in what way?
That's a great question. I don't know that I can answer it in one word. I think in many respects, the police have saved lives over decades. There are people who've been incredibly poorly. I know many myself where, if the police hadn't been involved, we would have lost those individuals. So there is no doubt that when they're the right people, they make a hugely positive impact. So it's a very difficult question. I mean, effectively, for many people, though, experiencing the police when they're in mental health crisis doesn't end well. So either there are long waits or, you know, it can re-traumatise. There are loads of reasons why, ideally, the police aren't the right people. But effectively, for years, we have operated a system where they have been the first response. Now, whilst we understand that first response needs to be shifted, it comes back to that point again around implementation and the how. So the police are sometimes the right people. They just are, because of the powers that they have.
Can I just add that? There we go. Just to add that, just as mental health care and healthcare generally has evolved over the years, I think it's probably true of policing because of the kind of, and the ambulance service actually, because of the kind of problems that exist today that didn't exist 40, 50 years ago. And in fact, as Sarah has said, the police are part of the response actually. And I have seen some incredible work done by police officers. I mean, it's definitely the case that, and we cover 12 boroughs in our big service, and there are some police forces, police areas where the response is so much better than others. There's a bit of a postcode lottery. And it's also something about experience. So, for example, Lambeth police are often really much better than other police, and that's partly to do with the fact that they work in an area where there's much more mental illness. What that means is that there should not be a simplistic blanket approach that the police should never be involved when a person goes into mental health crisis. And that's my concern here, that we're trying to impose a kind of binary approach on something that's actually more complex.
Okay, thank you. Thank you, Chair.
It's working now. Yes, come on to Southworth.
Just if I may, Chair, and hopefully some reassurance to colleagues here, because we accept obviously all the feedback from the panel, especially those who've not felt included in the process to date. So there's more we can do there, I'm sure. But we have found from the beginning of this process there is a slight danger of some myths developing around both right care, right person, and of course the Met's overall approach to mental health, because none of us, myself included, would ever back away from a situation where we felt that someone in mental health crisis needed our help. I myself spent 15 years as a hostage negotiator in this city, and let me tell you, the number of times I negotiated a bank robber out of a bank or a terrorist out of a hijacked plane were few and far between. Almost everything we do in that space is suicide intervention for people suffering mental health crisis, and our success rate, as colleagues have rightly acknowledged, in helping people come down from those very difficult situations they find themselves in is second to none in the world. So we have a solid and continued commitment to supporting people in the most extreme mental health crisis. And at the heart of right care, right person, of course, is a process whereby we ask ourselves at the point of the receipt of the call, is there an Article 2 or Article 3 right potentially at risk here, rights of someone either losing their life or of suffering, or indeed is there a criminal purpose, a policing purpose that requires us to attend? If any of those boxes are ticked, then of course we will deploy, and routinely still do, to 300 to 400 times each month to detain people under Section 136. So I wouldn't want anyone to come away today thinking that we're backing away from mental health, or somehow this myth that the Met doesn't respond to mental health anymore, because that's far from the truth. It's still a massive area of demand and delivery for us, and a really important, compassionate part of what we do for our public. So I wouldn't want anyone to go away from this thinking that we're somehow wiping our hands of mental health policing. We're not. I hope that's some reassurance at least.
Can I bring in Assemblymember Ahmed?
Thank you, Chair. Good morning, panel. So I'm going to be talking about responding to mental health needs, and my first question is to our Met colleagues. You'll both be aware that in 2013 there was an independent commission on mental health and policing chaired by Lord Adibawale. Could you say how the 28 recommendations that were made from that commission have changed the way that the Met responds to mental health, please?
Thank you for that question, Assemblymember Ahmed. And I should say this predates my time in this role, so it's some time ago, and I can't pretend to have been part of that response at the time. But obviously, Lord Adibawale's report at the time and the subsequent reports picking up the pieces were instrumental in pulling what is now our approach to mental health policing together into the state that it is. And many of the recommendations in that, there's 28 of them in total, so I won't try to itemise them here, were implemented as part of that, particularly around leadership and in terms of our frontline awareness, the creation of our mental health policing teams in each borough, so every single local authority has 2 officers who deal just with mental health. And backtracking slightly to a comment earlier about Section 135 as well, nothing has changed in that space. We still have mental health police teams who work with the AMPs in Section 135 situations to make sure that we work together to guide our officers in if police officers are needed to help effect a Section 135 warrant in the community to bring someone into a place of safety. So the report was a signal one, it was seminal, it was instrumental in creating those teams, in building our response to where it is today. Having said that, things have moved on an awful lot in that time, and right care, right person certainly wasn't conceived as a concept at that point. And I think whilst, as Martin rightly says, that transcends mental health, it has definitely changed the game significantly since then. So a signal part of our history, but something which now we've moved somewhat past. But Ali, did you want to say anything on that?
Sorry, yeah, just additional things that we've put in place in terms of the mandatory training that Mr. Southworth spoke about earlier, in terms of mental health nurses within our custody suites, which are there as a 24/7 provision by the NHS. If we look at, it's also spoken about not transporting persons in mental health crisis who have been detained under Section 136 in the back of police vans, which we're working extensively with the London Ambulance Service to try and reduce that as much as possible. So there are so many good things that came out of that report which are in action today.
You quite rightly, Commander Southworth, identified the fact that this was now 11 years ago. And an awful lot has happened, both culturally and in terms of various other issues that have come up. Could you just unpick? I mean, obviously, it feels very much as if it was a basis for the work that is being done now. But how are you building on the work of the Commission?
Well, I think the report itself was foundational, I think, and I wouldn't denude its role in getting us to where we are. But things like the mental health teams that we've talked about, the mental health liaison officer teams, are something that we're actively reviewing as part of the Strengthening Public Protection Programme. So what are we looking for from the roles of those officers, and how do they work more closely with our neighbourhoods teams, for instance, in identifying people? This may be germane to questions raised by my colleagues from mine and to my right around how do we better identify in communities those who are in distress but perhaps not in acute mental health crisis. So there's a role for us beyond just the immediate in the acute management of mental health crisis, and what the mental health teams do in terms of their delivery is something that we're actively reviewing as part of the Strengthening Public Protection Programme, how they work more closely with neighbourhoods. And if we are, hopefully, helping to reduce demand in some areas where we're 136ing, excuse that verb, but you know what I mean, less people, then obviously that gives us capacity to do other things. So there's been some great work through the concordat and with other parts of the partner agencies, try to build our response to mental health. In one area, for instance, we talked about Section 135s before. The mental health liaison officer worked really closely with the local team of AMPs and actually reduced the Section 135 list of warrants by half, I think it was, Ali, in one local authority, wasn't it? And that was just because they looked at them, some had been extant for a long time and thought, ethically, do we still need to do this? Can we get a family member to help? And they problem solved it in different ways rather than have to effect a warrant, which again is better because we're not disproportionately using our powers just because we have a warrant to do so. We're finding another way to find the right care for that person. Excuse that use of the phrase. So there's lots to do in this. It's iterative. It will never change. It will continue to develop. And the Adabawali report was a signal step in it. But yes, a long way down the line now from that.
Thank you. I'm so sorry, I couldn't see you there.
No, not at all. It was just in response to the report. That report was a seminal piece, and we all in mental health were incredibly grateful for it when it came out. What I would say, though, that there is a distinct difference between then and now in relation to what the Met perceive as core police business. So we understand that one of the primary recommendations from Victor's report was that mental health is core police business. We have been told, I think in just before the rollout of Right Care, Right Person by the Deputy Chief Superintendent or Commissioner, I'm sorry if I get it all wrong completely, that he doesn't consider mental health to be core police business. So which is it? Sorry, I'm asking questions.
Not at
No,
all.
well, no, I think that's
Perfectly fair.
Would you mind answering that, please?
Of course, absolutely. And public safety, I think, is, and my commissioner I'm sure would agree with me, is our business always. Preserving the peace and keeping people safe is fundamentally our business. Protecting people's Article 2 rights is our business. And when that means we are required to support people in mental health crisis, as I say, whether it's a negotiation situation, whether it's a Section 136, we will always deploy to support the public. And I'm really keen for the public to make sure they hear that. You know, we're not turning our back for 1 second on anyone in crisis, let alone people suffering mental health. But where I think the Commissioner would be accurate in his viewpoint, and I'm sure my colleagues will agree because it reflects what we said earlier this morning, is mental health illness, as the title suggests, is a health and illness matter. First and foremost, it is for experts in that field to help support people suffering from mental health illness. We have a role, we absolutely agree and concur with that, but it isn't necessarily for us to be the lead agency in dealing with mental health illness. How we support people in crisis and in critical situations is, but more broadly, we need to be far more closely collaborative with our partners in the health service than to be leading in an area where, as everyone's attested today, we are not the experts.
Dr. Smith, you wanted to say something?
It's just say that there's, we have been focusing on what happens at the point of crisis, but of course policing, as you've mentioned, involves public safety, and one of the concerns that we have is that, and this may be something to do with the way in which it's been implemented, but I think that the point that Mark Crowley said, mental health isn't core policing business. One of the difficulties that we've had is that unfortunately patients with mental health problems are often victims of crime. And in fact, the staff who work with people with mental illness are often victims of offences as well. And whenever an offence happens either in or near a hospital, or a mental health patient's involved either as a victim or even perhaps a perpetrator or both, increasingly what we're finding and what we're hearing from our membership and from the mental health trusts is that the police won't get involved, because the police are saying, this is a mental health patient, go to the hospital, or this is nothing to do with us. And I have to say, I'm very impressed with you. You're a very senior officer, and clearly you're an excellent negotiator. We can see that. But I'm
absolutely, yes, I want you on my team for sure.
Yeah. But I am concerned that actually the message from the top has been incorrectly applied on the ground.
We are going to be looking further and in detail at Right Care, Right Person in a few minutes, so I'm sure we'll come across these issues and go into them in a lot more detail. My next question is to NHS London, Mr Machray. The Mayor's Police and Crime Plan commits to providing an alternative to 999 for people in mental health crises, to provide 24/7 access to advice from mental health professionals and helping managing bed space across London. How is NHS London working with MOPAC and the Met to deliver on these commitments? Could you also say what progress has been made and what has been the result, please?
I'll try and cover all that, yes. Thank you. So in terms of how we work with MOPAC, yes, we work with them every day. In fact, I've got a team leader in my team who is our day-to-day liaison with MOPAC and the Mayor's office. That covers a range of issues, from how we work with the police, how we provide care in police custody suites, how we support the marine team along the river, how we deal with suicide, and there's a whole range of services which are provided mainly by our mental health trusts across the city, but are coordinated and commissioned from my team. That works really well. You've heard evidence today, I hope, that we are committed at a senior level to partnership. I recognise the point that Dr. Smith made, that actually the headlines lead to unintended consequences at a local level, and people will believe what they read in the press and ignore the guidance that we formally issue on our pink memos, for those who remember pink memos. And it takes a lot of time to change that practice, but that's the work that we're doing with the Mayor's Office for Police and Crime. That's the way we see it working. As for impact, the impact measures are across a number of areas. I'll give you an example of where I think there's been a really positive impact, and I'll give you an example of where I think we've got more work to do, if that's helpful. So in terms of a really positive outcome, I think the fact that we set up the clinical advice line to support police in making decisions before they apply a Section 136 can only be a good thing. And partly the reason we've seen a drop in 136 usage is because the non-experts have sought advice from the experts, and we've been able to route people to a better place. Now, that's a good outcome for many people, though, as we've heard already from Dr. Hughes, we're always worried about those people who are lost in the cracks, and we'll always worry about those. There are some areas where we've still got more work to do. And the area that we are seeing, for example, using 136 as the example, is when people are already in police custody and 136s are applied. Now, that can be very appropriate, but we haven't seen a change in that data over many years. So that's probably multifactorial. We need to understand it much better. But the consequences of that are, and we've already alluded that we knew 136 usage was too high. We know that 136 usage is too high in young black men in this city. You are 4 times more likely to access your first mental health services through 136 if you're a young black man than the rest of the population. That can't be right. Now, that's a partnership problem, not a health or a police or a public sector or a community problem. That's a partnership problem which we've got to put right. So there's 2 examples where we're working in that partnership with MOPAC and others to go, right, so what do we do about the challenges that still face us?
Thank you. Could just a resourcing question. The advice line that you were talking about, how accessible is that and how well resourced? So, you know, I've been out on ride along with the police where, you know, 3 of the cases that evening were all about mental health crises. How accessible, if there are 10 different incidents happening across London, would it be for police officers to speak to the relevant person?
So the evidence we've got is that they're readily accessible. The longest wait for a response was in January and December was 25 minutes. Now that, when you're a police officer at the scene of an incident, must seem like an eternity. But in the grand scheme of things, it's not a bad response, it could be better. In terms of how that's resourced, the 136 hubs, there's one in the south of the city, one in the north of the city, and they work across the 2 to support each other, to make sure resources are available. They're funded by the NHS solely. We've been working with MOPAC and with the Met Police because we think we're providing a service to the police, and we'll continue to have those discussions about how we fund those things ongoing. In terms of overall cost, it's just under £1 million for a year.
Okay, thank you. Thank you, panel. Thank you, Chair.
Thank you. I'm now going to bring in Assembly Member Prince.
That's okay. I think most of my questions have been answered. So.
Excellent. So we will now move on to Assembly Member Lord Bailey.
Thank you, Chair. Good morning, panel. I'm going to address my first question to the LAS, and then maybe the MPS might want to chip in as well. The Mayor's Police and Crime Plan commits to deploying London Ambulance Service cars rather than the Met for people in mental health crisis where appropriate. How are you working together to deliver this commitment, and what impact has it had so far?
So Alison already explained about our mental health joint response cars. So those are the 6 cars that have a paramedic and a mental health nurse on, which are proven to be very, very effective. The next step, and I wanted to compliment the police on this bit, was that the ambulance service is responsible for transporting patients under Section 136. You could take a police officer, in theory, in the ambulance vehicle to the hospital. LAS hasn't had the resources to be able to do that routinely for many, many years. So that responsibility has actually defaulted back to the police. And when the police said, we're implementing RCRP, they said, we want to stop doing this. And we said to them, well, until we have sufficient resources, that would actually make a whole group of other patients be disadvantaged because we wouldn't be able to get to them. So in the planning, we agreed with the police that they wouldn't pass that responsibility to us until we had the right vehicles and the staffing to do that. So from the spring, we have agreed, we're getting delivery of specialist mental health ambulances, which don't look like an ordinary ambulance. So they're not yellow with green Battenberg. They're grey with the blue flashing lights, but are a way better aesthetic, calming vehicle than a double-crewed ambulance. So from the spring, the Metropolitan Police will spend less of their officer time taking patients to 136, the 136 patients to hospital, because we'll start doing that. So that won't reduce the number of Section 136s, but it will reduce the amount of police time, because rather than needing 3 or 4 police officers, you'll only need 1 to go with us to do that. So I wanted to put that on the table as we think that is good joint planning, where we accepted what the issue was the police have raised and agree with them a timetable by which we can do it. So that bit is coming, and I think that will lead to a further improvement in the care that these patients are getting. And I would kind of describe the whole conversation as we started with something that was very imperfect for a lot of people. Mm-hmm. And in doing this work, we are gradually taking some of the imperfections away. So it is by far from being a great service we're offering to all patients. But I definitely think in the last few months it has got better. And I think we've got plans to work together to make it better still. And then the piece I just wanted to then flag was currently we're in negotiation with how are we going to get paid for doing the extra work that is coming our way. Which we're in, there are lots of conversations going on about where that funding might come from, but we're definitely doing the right thing for people.
Dr. Smith?
Just a very quick plea. I think that's it's fantastic, and we've heard about the extra ambulances. But could I please ask that the ambulances look exactly the same as all the other ambulances? Mm-hmm. Because if you have grey ambulances, and everyone will know that, here's the van coming to take you away, and it's going to end up being stigmatising, discriminating. So, the mental health ambulances will know that they're mental health ambulances, and they'll be deployed appropriately. But please, could they look the same as other ambulances?
So we can take that back, but this was a national specification for these vehicles, and lots of research was done about what they should look like with lots of groups of patients. And the conclusion was it would be much better if they didn't look like an emergency services vehicle and looked like something that was more like a car.
Sorry to interrupt. I think the doctor may be onto something here, because you've said looks more like a car, because I'm thinking, why does it have to look like anything other than a car? But you've also said that it sounds like it won't look like a car. So if it looks like some type of ambulance as opposed to a normal car, it then should look like an ambulance.
Alison could explain what it exactly looks like, because we've got one, so we can...
Thank you. So I really take your point, and as Daniel said, the specification was driven nationally with involvement from lots and lots of different groups, including patient groups. I think we have the potential to do something different in London if that's what we want to do and what we think is the right thing. So absolutely can take that away. As it stands at the moment, those vehicles, when they arrive, will be essentially, it's a small van. It has some ambulance marking on it. It has blue lights, but they're covert blue lights, so they're not a big kind of bar across the top. And then in the back of the van is a seating area and a table, and it's the same type of vehicle that some of our officers use for attending incidents and events. So we already use a very similar type of vehicle for some of our current resource already.
Sorry, can I just add as well, and this is really important, a significant proportion of people with severe mental illness especially have comorbid physical problems. And in fact, our patients die 15 to 20 years earlier than everybody else of the same natural causes, cardiovascular disease and respiratory disease. And when they're in crisis, they're at particular risk. So again, another plea to ensure that the paramedics and the ambulances are able to deal with people's physical health problems as well. And again, I have to say that I think the patient groups that we're involved in, we have 250 patients who work with us at the Royal College of Psychiatrists, and I cannot think of one of them that would be happy about being taken away in a van that looks very obviously like a mental illness van.
Dr. Hughes?
Yes, I mean, I have to say the description of the ambulances fills me with a little bit of dread. Having worked in mental health for 35 years, I can tell you that the, white coats and the people chucking people in the back of a van image came to mind, which is a bit depressing. And it's interesting about the engagement with lived experience groups, because one of the things that we wanted to talk about here is, again, in terms of the measures of who's talking about this as a success. And we know our lived experience groups, yours, are not engaged in this conversation. And indeed, it was just last week that a lived experience group was brought together from the Oversight Committee. So I'm interested in who are these focus groups? Are they specifically mental health patients? And if not, why not? And if so, who? Because I'm quite clear in agreement with Lade. I don't know one person who would support that. And then the second question is about the point you make in terms of we're in negotiation around paying for the extra work we're going to do. That's a critical point, because again, that comes back to the rollout. So we're hearing, and this is not for London, but we are hearing in other parts of the country where ambulance services are also saying, well, you know what, we are not going to pitch up to welfare calls either. This was said 2 weeks ago. So based on, we are not being paid for this additional work. So the issue of resourcing other services is profoundly important, because what will happen if you are not paid for that additional work? Are you also going to say we're no longer going to be able to respond to these calls?
So just come back to the vehicle design. So we have one in our possession. We're very happy to show you. We think we have a vehicle that is very well designed for a large number of patients, because most of these patients can sit and are in a place where, if you have the reason why it's quite it's a van design, it's somewhere between a car and an ambulance, is so you can have 4 or 5 people sat comfortably, safely in the back, and you can do an assessment in a private space too. So, and then the boot is full of all of the paramedic equipment should you need it. Clearly, the patients who are really, really ill, who need to lie down, you need to send an ambulance. So we're not going to not send ambulances, but I think we have designed something that is actually going to be materially better than the current conveyance, particularly if the current conveyance is the back of a police van. And the whole fleet is fully electric as well, incidentally, just to contribute to our green credentials. On the are we not going to go if we don't get the funding as London Ambulance? So we are really committed as an organisation to providing the best care that we can, that is tailored to the needs of the individuals who have phoned us. I don't think we're going to be in a place where we say we won't respond. We think that what's happened in the last few months is the response these people are getting is much better now than it was when the police were doing it by themselves, because we might not be perfect, but our teams have way more, in general, skill and expertise at managing these people than police officers. So it feels to us like the transfer of work is right. I think the NHS will come good, and there will be a negotiation at the top of the NHS and the government to actually get the funding to happen, because it's the right thing to do for these people, and we're now offering a better service to the taxpayer than we were before. So I'm hopeful it will come right, and we won't be in the place where we're saying no. And I think all of this joint work in the mental health space between us, the Mental Health Trust, NHS England and the police has been actually quite exemplary over the last few months of working together to solve a really difficult problem, which isn't to say all the problems are solved. I'm with you that there's loads more to do on that side of the table.
Chair, back to you.
I think you were going to hear from the MPS as well on this question.
Only if they had something else to add.
Does the MPS want to come in at this point?
Oh, sorry, Ali. I was just going to say, if I may, do come in. I was just going to say, if I may, thanks to, obviously, Daniel and Alison and the team, what we should note there is, and we haven't actually covered this yet today, of course, is that the Right Care, Right Person programme was initially piloted in Humberside, as most people will know. So Ali and I actually went to visit the Humberside team in Hull and see how they delivered it and so on and so forth, and learn from their experiences there. Subsequently, it's gone on to become what will effectively be College of Policing approved national best practice in policing. So this, just again for clarity of all, this wasn't something that London, or specifically the Met, decided to implement in isolation. This is a national programme of transition for policing UK-wide and partners. And I suppose the point that has been well made both to my right and left there is that we're aware that the relationships aren't always the same around the country between police and ambulance. In fact, if I may, I think the relationship between the Met and LAS in this instance has been exemplary. So thanks to the LAS team, because they are indeed taking that pressure off us. And as Daniel rightly observed before, we've not come at this from a clumsy point of view and said, well, we're just stopping on day. We've got a phased transition to a greater LAS involvement in transport. So again, my record of thanks, if I may, to them, and an acknowledgement that it's not quite as healthy perhaps elsewhere in the country as it is in London.
Dr. Hughes, you wanted to come in, and
really
then
briefly, yes, really briefly. I have to say that the view and the assessment on exemplary joint working, I think we probably will need to agree to disagree, because again, relevant experts, people with lived experience, non-public agencies, and so on. So the version of exemplary public engagement is all of that as well. And I think that it's, again, really important to nail the point about funding, because actually in Humberside, which is where the best practice comes, which actually Mind is big part of. I've also been to visit, very pleased and proud of what they've been doing up there. But what I would say is that it took 2 or 3 years for that service to be developed. Huge number of relationships had to evolve. Funding had to be negotiated and agreed between partners. And I have to say that there has been, since the national rollout, deterioration in some of that for all sorts of interesting reasons. And I suggest colleagues go back to Humberside and have some of that conversation. And we also should tackle under 18s before we go.
Yes, definitely. Assemblymember Moema, you wanted to come in briefly, and then Assemblymember.
Yeah, very briefly. I was just listening with interest about this argument about what type of vehicle there was going to be. And as you know, I'm normally studiously neutral when I'm in committee, but I'm generally quite horrified. The vision of people being thrown into the back of a car. I mean, I'm being hyperbolic intentionally because that's what it will look like. There is a separate ambulance for those people in mental health crisis, and they're being marked out and they're being taken away. It seems to create a new problem that doesn't exist at the moment, rather than moving people just over from the police to the right agency. But my question was going to be to the Met off the back of Dr. Hughes's point about Humberside. In your experience, when you were rolling out Right Care, Right Person, when the trial happened in Humberside, it's my understanding that most of the referrals, if you like, the calls to the police were from mental health partners and social care partners. How does that compare to how things have rolled out here in London?
Yeah, it's very difficult for us to, when we look at the calls that come in to the police control rooms, it's very difficult to distinguish what are coming from partners and what are coming from members of the public. We have done a deep dive into the data before we actually went live, and you're looking at between 70 and 80% of those calls that are health related, so Right Care, Right Person related calls are coming in from members of the public. 20 to 30% are from partner organisations, for example, asking us to go and check on the welfare of an individual. So that's roughly what the data suggests.
And is that something that's going to be tracked over time to see if that's actually working or is producing positive results?
Absolutely. So part of Right Care, Right Person, the formal boards and subgroups, one of those is data, which is led by the NHS, and we're all doing deep dives into our data to see how that is changing.
Thank you. Yes, and then I'll bring Assembly Member Hall in.
So we too went to our colleagues in the Ambulance Trust that serve Humberside to find out how this worked. And I think the refinements we have made to their model in London now mean that the London model is the one that will get rolled out around the country. So the improvements we made to their model were having clinicians to triage the referrals when they came from the police. So rather than in Humberside, the police just put the call into the 999 system, so a 999 operator is answering it. In our system, the police are sending the referral essentially over an IT link to an email to a dedicated group of clinicians who triage the call. That means you're getting a much more quick and tailored response that's right, quicker. And I think that bit, I think, is really good practice that is better than the Humberside model. And I think our joint response cars are also something which other parts of the country will want to emulate as well, because putting paramedic with mental health nurse professional together makes a really big difference. Just one more thing on vehicles. I don't know. So we think this is a good thing, and so we've managed to pitch this not right to you. So we have a fleet of 1,100 vehicles. Only 550 are actually ambulances. So increasingly, the response that a member of the public gets when they phone 999 is not an ambulance. It could be a bike, a motorbike, a car, a van. So if you take our community joint response vehicles, so that's a community nurse with a paramedic. Some of those are transit vans that are converted, but they're all sorts of different kinds of car that a lot of people do not need to lie down to get to the place where we convey them. And the symbol that an ambulance says is you're lying down. The symbol that a purpose-designed car is sending is that you can walk into it and you can walk out of it. And the design of the interior has been beautifully designed to be ligature-free, to have plenty of space for people to work in. These are good, well-designed vehicles, and they will provide a good patient experience.
Thank you. Assembly Member Hall.
Yeah, I think I'm very positive about this, and I must say to say thrown in the back of lends no, but it's not correct. They're not being thrown in the back of anywhere, and I think language like that doesn't help. And we mustn't forget the reason this has all started is that police officers used to take patients to hospital and be stuck there for hours and hours and hours because nobody from the mental health department could come down for reasons I'm sure were valid, but it still meant that our officers were stuck in hospitals for hours and hours and shifts, and sometimes another shift had to come on and take over from them. That is not what the job of the police is, and it's no good us on the Police and Crime Committee having nothing but a go at the police because they're not catching thieves when they're all stuck in hospitals because no
Assembly
medical
Member Hall, my point was completely separate. That was not my point that I was making. It was to the ambulance service, not to the police. I agree with you. It was the point that I was making.
Well, I love that you agree with me. I'd made two separate points there. But throwing somebody in the back of a vehicle.
Can we move on to the questions?
Yes, we can now. Thank you. Right, I'll put it all in one and I'll talk to Commander Southworth, I think, please. A new Met for London states that by January 24, the Vulnerability Hub will be delivered in full and will offer a range of coordinated interventions that can be enacted more quickly. Is the hub now fully established, and what does that future of the hub look like?
Thank you, Deputy Chair. The hub isn't actually fully up and running yet. We are piloting it again at the moment in two of our largest BCU areas, which is South East and South Area, which covers 6 local authority areas with the highest volume of both missing persons and, I think, to some degree, largely mental health Section 136s as well. So the reason that we've had to go back and re-evaluate is that the first pilot that we ran last year was only a 48-hour pilot, and there was a concern that we needed to get more detailed academic study on it before we rolled it out Met-wide. So whilst I should apologise to the committee in one sense, since that it's not in place in full just yet, there's been healthy caution around that because our senior leaders have decreed that we need to make sure we are 100% evaluated of it before we actually roll it out in full.
Okay.
So the commitment is no less, it's just we're making sure we're doing exactly the right thing in exactly the right way before we go to full delivery.
Okay, and have you got timings for that, or approximate timings?
So the evaluation, the pilot is underway now and will run this week and next week. It's already showing some early successes, but some early learning as well. If that's evaluated and deemed to be absolutely successful and the way to go, then we need to obviously recruit the workforce to actually make it Met-wide. So that could take us a few months. So forgive me, I wouldn't want to definitively specify a month, but I think realistically that would be the summertime before we can actually get it rolled out in full, which does put us behind on where we'd like to be. But I think it's something that it's important we get right before we make such a significant change to our approach, not just to how we deal with mental health section 136s, because the vast majority of the vulnerability hub is actually around how we manage missing persons and whether they're children or adults, and deal with concerns around exploitation, which, as you'll know, of course, is very germane to the HMIC report, which is with us now, but it will be released on Friday, which relates to the inspection around missing persons and exploitation, which is a whole different area, but which we can't ignore as we seek to do something so signal.
No, that's right. How is the Met responding to intelligence and supporting people in London that have purchased substances online to assist with ending their own life?
So, as sadly people will probably be aware from some media coverage, there has been one quite high-profile case which emanates from overseas where it's alleged that an individual was selling sodium nitrate kits online, which people were sadly acquiring and in some instances possibly using to take their own life. In any such instance like that, the police, and of course not just here in London, but supported by the National Crime Agency and other forces, will go wherever the evidence takes us, including overseas if necessary, and where we have jurisdiction to do so, to pursue those who might be responsible, because anybody involved in assisting in a suicide or providing illicit materials in that way could potentially be breaking the law. So it'd be wrong of me to comment further on that specific case, but that is one of the things that's brought it to notice. We are embarking on some work to work with partner agencies and in the online space to see if we can identify any more of these purveyors of what might as well be termed poison, so that we can hopefully safeguard people. What I would say, and actually Detective Superintendent Vanna was leading on this for me, was that wherever we do have it flagged to our attention that somebody may have purchased one of these kits, we try to make sure that we get ahead of that and put a safeguarding response in place to make sure that those people don't then follow through with what could potentially be their own suicide. But again, we need to be very mindful that there's a coronial process potentially behind each and every death of such nature. So much like the investigation, I'm a little constrained in what I can say in more detail about either of those.
No, it's a very concerning
phenomenon
development, isn't it? I mean, every time you think you've cracked something else comes along. I mean, as it's Children's Mental Health Week, how have you been supporting young people who are potentially turning to online suicide kits, or young people who are experiencing a mental health crisis?
Some colleagues actually around me may want to come in on that, but I would say from the Met Police's point of view, the main response for our safeguarding course of children comes through our multi-agency safeguarding hubs and of course our child safeguarding processes. So rather than be distinctly through a mental health illness lens, it's more a case that where we have children coming to notice it for potentially risks of suicide, then obviously working with CAMS and others, we would bring that to the fore through our multi-agency partnerships, strategy meetings, and try to make sure we get the right intervention and safeguarding in place for that child or young person. So it isn't something that we particularly accelerate or decelerate at this time of year or any time of year. It's a rolling, continuous endeavour for us to make sure that we get the right solutions in place for children and young people suffering mental health who may be at risk of taking their own life. So it's a very involved process, as you know, with the multi-agency safeguarding hub and reporting and referrals, but probably beyond what we can discuss here today, I'm afraid.
Yeah, okay, perhaps privately another time, because it's an interesting aspect. Thank you, Chair.
Thank you.
Thank you. We're now going to take a brief comfort break before we move on to our final section of questions. So the time now is 11:32, so we will come back in 5 minutes. So that's 11:37. Yeah. Just about to go. Welcome back to the morning session of the Police and Crime Committee, and I'm going to move to Assembly Member Pidgeon for the next questions.
Lovely, thank you. And I want to sort of get into a bit more detail of right care, right person. And I've heard very clearly, good idea, but it's how it's been implemented. And I think that's what's really come out from the discussion this morning. And clearly, so much work has gone on, as already been described, when Humberside took 3 years, and this has been done in sort of 6 months. So there are clearly issues there. So work clearly went on with or without the voluntary sector by the sound of it. But I'm wondering what you're now doing to review how it's been rolled out and how you're bringing other partners in to see what's worked well, what hasn't worked, and perhaps talk through some of the challenges, please. I don't know whether that wants to be Alison. Maybe you, Kevin or Alastair, want to start with that?
Happy to open up, if I may, Assembly Member Pidgeon, and I'm sure my colleagues will join. I mean, thanks again to my peers around the table, Alastair, as you say, but also Martin and the team, and likewise Alison. We all sit on a joint board, which Martin kindly chairs, and I co-chair with him. And this is sat monthly, really, since we've rolled out Right Care, Right Person.
And who's on that board, just to clarify?
We have a wide range of stakeholders. Martin, did you want to?
Yeah, so police... clinical input from the NHS, managerial input from the NHS, Mind are on it, lived experience and experts by experience are on it, and local authorities, children's services, local authority, adult services. So it's a wide range of people. So just to give the myth at that level that we're not engaging, we absolutely are.
And then was that there from the start, or has that just been since it's been implemented? Okay, I'll bring you in a minute. So you've got this structure now. Talk me through then how it's working, how you're reviewing it.
Well, at those meetings, we routinely review all the data in relation to many of the points we discussed here today, which include, of course, numbers of Section 136s, but the entire process end to end. And that's not just from the policing perspective. Of course, partners bring their own data as well, so London Ambulance Service and others. And then, of course, we'll track through the different activities that are undergoing, and there's some work with the experts by experience pool and to check what the experience is of those who are on the receiving end of the services that are provided by all the partners around the table, and equally each of us as equals make sure we gives our input to that. So it's just, I suppose, in many senses, notwithstanding today's feedback about the broader concerns of colleagues here today, it hasn't been anything other than resoundingly successful in many ways. I think I don't want to make that sound too polished. I can clearly hear the concerns from colleagues, and we undoubtedly can engage and do more and improve. But largely, it's been the success factors have been high so far.
But what's proving to be more challenging? There must be something. It can't all have been plain sailing. No, this is a huge change.
Indeed, and we haven't yet had for instance, we're monitoring for any critical cases that come to light that might underpin perhaps one instance where something has gone wrong where we haven't deployed. I'm sure at some point there will be, because whenever there's decisions made to deploy or not deploy, something inevitably will test our thinking on this. But at this point, the overall overwhelming improvements that have been made, as Daniel said a moment ago, would significantly outweigh any sort of concerns that we have about how we've gone about this. I think to my colleague's point about the timescales, the differentiation there would be that whereas when we visited Humberside, it was a pioneering inaugural thing. So the Deputy Chief Constable, Paul, who hosted us there, has done an amazing job to formulate this response, and we all owe him a debt of thanks, I think, from a policing perspective. But the very reason it took 2 years was because it was groundbreaking. Once it had been pioneered, we had a ready template to copy, which they gave us, of course, exhaustive detail on. We came back with many lever arch files, didn't we, of how this had been done. So... And then, of course, the College of Policing have effectively validated it as well. So we didn't have to go through that extended process of trial and testing, because the ground had already been paved to some degree by the Humberside experience, and we've sought to replicate and where we can improve on that.
Though, of course, Humberside is not London, and London is far more complex and has far more diverse communities and issues, probably than somewhere like Humberside, though I can't speak for them, I don't know it at all. Could I come to the ambulance service? We'll come to you in a minute, but can I get to the ambulance service and understand from your point of view what's proved more challenging? Are there any areas? Obviously, resources is one that you mentioned earlier, which is the other thing, how sustainable this is. But Alison, do you want to come in?
Thank you. So I think some of our biggest challenges have been dealt with in live times. So when RCRP first launched, we placed some of our clinicians into the Met Police control room, and actually that allowed us to jointly assess calls as they were coming in and really understand what that person needed. So what might have then presented as quite significant challenges were dealt with in live time between the police and the LAS. So that's a challenge, but also a positive. I think one of our biggest challenges as an organisation at the moment is welfare calls. And we've certainly seen an increase in calls coming directly to us for concerns for welfare. And whether that's a mental health patient who has left care, or whether that's someone having a crisis in the community and now can't be found, or actually whether that's a patient who's left an acute trust or hasn't attended for an appointment, a planned appointment, we're seeing all of those calls now coming into the LAS. And actually, some of those calls are really quite difficult to triage. We have a very systematic triage process within our control rooms, and a concern for welfare doesn't easily sit within any of those patient groups that are triaged through that process. And I think that's one of our biggest challenges at the moment, and the group that Martin chairs has picked up that issue, and mental health, acute trusts and us are working together through how we might better respond as health to some of those patients.
So it's putting more work, if I can put it that way, to the health sector, and you're then having to do additional work with key partners to find a way through that so that the person gets the right and best service. Yeah, and I guess I'd add to that actually those calls aren't police calls either. Absolutely, thank you. That's really helpful. Let's come over to our friends here from Mind, and shall I start with Dr. Smith? You've got your mic on. I could see you're keen to come in. Let's get your perspective on this. Obviously, there's some issues about the structure and you being at the table, and it sounds like there might be some disagreements about that. But going forward, what challenges are then? Where do you see how you and your colleagues could be involved to help shape this, to improve it?
So just to reiterate, we think the idea is a sensible one. However, even just listening today, what's very clear is that the metrics that are being decided about whether or not this is a success are very much police metrics. What we've not really heard about is the impact on the health service. So I think Mrs. Hall mentioned about the reduction in 136s and how useful it was because it was helping reduce the amount of police time in A&E. Now, this is a very important thing. It's not simply about what happens at the front door and coming into services. It's also about what happens in people's experience when they're in services. So we know that when people go into A&E, unfortunately, they have to wait. I mean, people with mental health problems have to wait sometimes days to get beds. And it doesn't make sense for the police to be the people waiting to hand over a person on a 136. There are all sorts of paperwork things that have to happen. There are things that can happen. There are initiatives that can happen to support that, but they're not simply about, great, it shouldn't be the police, or even as A&E staff are saying, or some, for example, the Royal College of Emergency Medicine is suggesting that security guards would take over that role. Actually, what we need are more mental health staff, and there are various initiatives that could happen. That requires resourcing, actually. So, for example, psychology graduates could be people who act as essentially kind of associate nurses, if you like, and to do the observations. They could help with the handover and the coordination and moving people on. But that takes resources. Likewise, when it comes to not simply welfare checks, but people come into A&E long before they actually get seen by a mental health practitioner. They're waiting to be seen, and they might disappear, they might run off. A&E staff then have to call the police to say, we've got someone, we think they're vulnerable. And what the reports that we're getting is that the police are saying, actually, this isn't us anymore because you think they might have a mental health problem. And the difficulty with that is that in some cases, and these are actual examples, A&E staff have been asked to go to a person's house to look for them. That takes the staff away from their place of work. We've also had the problem as well in mental health settings where people have gone absent without leave, and these are people who are vulnerable, who perhaps run away in order to harm themselves. And again, police have said, well, this is a mental health patient, you have to go looking for them. So we've had staff, nursing staff, leave wards that are already stretched in terms of staffing, going to look for patients. And that then has quite a negative impact on the safety and the quality of service that we can provide. So it's working from the police's point of view, but there are consequences that we haven't had the time to build up the systems to properly record and monitor the impacts on the health service, actually. And that's it's really important, because we can't just say, well, this is working on this side, when in fact the balance on the health side is terrible, especially because we're already talking about very, very, very overstretched service. So yes, we are very keen to work in partnership, and in fact I met with Matt Twist, who's the Assistant Commissioner, last week, and we spoke about this. And he admitted actually that there are limitations in the understanding of what the mental health, what people's mental health needs are at a number of levels, actually, at the local bobbies on the beat level, at the borough commander level, and even at the more senior level, particularly in terms of the law and mental health law, actually. And we have, as a college, we do lots and lots of training, education. We said, we'll help with that. We're very happy to help with that. And we're also happy to help with developing databases to help understand what the impacts on the health services are as well.
Yes. Very interesting, thank you. Dr. Hughes.
Thank you so much. And I am going to preface this with, I'm saying it with love, okay? But nonetheless, I have to say, I absolutely disagree in terms of the collaboration and the partnership. We were not there from the beginning. In fact, I had to twist Matt Twist's arm to get a place around the table. So I'm afraid, Martin, we can agree to disagree. We can agree to disagree on that, but I was in that conversation. And that there's a great deal of risk there that there is an echo chamber. So let's just pause on the fact that people with lived experience either, whilst they might be sitting around the table, I understand that correspondence and dialogue with them at depth has not yet happened, and we're hoping to support with that going forward. And of course, we don't know what we don't know. So in terms of the discussion and the examination of adverse effects, we already see from the from the prevention of future death notices that come out of the coroner's courts that there is a huge amount of lessons to be learned that I'm not too sure have been translated into Right Care, Right Person. Indeed, Nottingham have paused the rollout of Right Care, Right Person because of recent events. And so again, when we think about looking and examining the adverse events that we know are happening within the system, they're not anecdotes, they're lived experience. It is about being able to collect that data and evidence. Equally, we might have to wait some time before we get outcomes from coroner's courts. So unless we have system-wide data, then those adverse events are going to go under the radar. And I'm afraid that is a great risk, especially, again, when we're thinking about children, young people. And just my final point on the funding for alternatives, which is, this policy will be super brilliant if we have a system-wide funding for alternatives that actually works for the population that we're actually talking about.
Yeah.
Absolutely.
Actually, can I just add about children and young people?
Yes.
But we do know that since Right Care, Right Person came in, unfortunately, safeguarding alerts for children and young people have reduced. Now, that's a concern. Obviously, it's everybody's business. And we are concerned, and the police are really good at flagging when, there's a problem here with this child, this kid should be, the social services should be looking at it.
Yes.
And that was an important, and we know that social services are very overwhelmed, but if a child is in need, that child's needs should be addressed.
Okay, thank you. Lynette, did you want to come in?
So I was just going to add, it's very interesting to hear our statutory partners talk about mental health and the rollout of this programme. And how well it's doing without the voluntary sector in those conversations, because I don't know how you're measuring it. What I do know, across London, we have already seen over the last 12 months an increase in the complexity of people that are coming to us, because we work alongside the statutory services and we know their criteria are changing. So to say this is all going very successfully just because we've got less people being sectioned doesn't really take into consideration all the services that actually the NHS commission us to deliver. So it's really remiss that we're not there, the people that are actually delivering on the ground in these conversations. We ourselves at Haringey run a crisis cafe. We know the people that are coming in, and actually the ambulance, when they are triaging to some of the crisis cafes. So what we're not doing is learning from each other and actually being around the table so that we can see how this is working on the ground. We want it to work. I think you've heard that from us on more than one occasion. But to not have us there and understanding on the ground what that looks like in London, which is totally different from Humberside, is really remiss if you want this to work and if you want it to be good for the taxpayer.
Thank you, Lynette. Martin, I know you've got to dash off. Could I just bring you in terms of the metrics around health, because there'll be a bigger impact there, and some of these issues about involving key partners such as Mind and their members.
And again, I'll reciprocate with love. So I absolutely agree with Dr. Smith. We need to see the health impacts of this, and we are going to be measuring this. I heard an offer there to help us with that data. I'd be really grateful for that. But we won't see the impact of this in 2 months or 3 months. It'll be a longer piece of work. And in fact, the Mayor asked that there was an independent study about the impact of this, and the Office of Health Improvement and Disparities has offered to help with that. So I'd be really keen to work with all colleagues on that. Just to be really clear about what I was saying about involvement. The Commissioner announced the rollout of RCRP in the late spring of 2023. The first committee that we set up as a response to that announcement was in July 2023, and all those people I mentioned were invited to the meeting that I host every 2 months since that point. That does not mean that non-statutory organisations have been involved fully in the rollout of RCRP, because it's a national programme that's been driven forward from other things. So absolutely see the need to continue to work, and as Lynette, you've just said, work more at the base. And I do say this with love, we can't deliver our mental health services without the type of service you've just described. In fact, the NHS is probably the worst group of people to deliver those services. So we work really well. We're not painting a glossy picture. We're painting a picture of how we've responded well to an immediate demand from the Commissioner to implement this policy. And I think we've done a good job in rolling that out. And I'm afraid, Chair, I will have to leave at this point.
Thank you. Thank you so much, as always. I think it seems to me, and I'll finish here on this section of questions, that actually it's about the sustainability of all of this, because it's all exciting and you've got the focus of the Commissioner. I was around when Lord Victor Adebowale came in and did that, and colleagues of yours sat there and were so passionate about mental health. Then the Commissioner changes and the focus moves on, and actually it's a lovely document we can refer to and some of us remember, but actually things move on. So it's just making sure you've got the resources in there for this to work, and the health side, because there's no good sort of police. We've dealt with it and it helps with what you are trying to achieve, but ultimately the other parts of the system are picking this up and making sure they've got the right resources. I think it's really important. I'll leave that section there. Thank you, Chair.
Thank you. And we now... actually, you are going... Sem wanted to come in. Sorry. Assembly Member Marama.
Two of my three questions have been answered. But this other question... well, it was primarily for the NHS, but others may be able to comment. So within the context of the last 15 years... we've had massive cuts to each of your services budgets into the voluntary sector. It's a shame social services aren't here, but because I think they're quite fundamental to resolving this. So sorry, not sorry for having a go at you, but the point still stands. But I appreciate that this is something that also involves social services, and the police have been the agency of last resort for the last 13, 15 years. So I think we all have a lot of sympathy for why this is happening, perhaps not the how. was the point that I was trying to make earlier. But in having the way that you described what you are doing, I have no doubt that it's well-intentioned, but it really makes it seem like any mental health responses are going to be second order to a physical health response. I think this is how it came across, and I'm sure people listening at home, that's how it will have come across. And I think within the context of London, where it is different, the population here is different. Your sample area, South London, has a large black and minority ethnic community. Each of your agencies has issues around disproportionality within its staffing and the way it treats Londoners, and they're being dealt with to varying degrees. I guess my point is that concern that I was expressing about making sure that right care, right person is not a second order for a particular cohort of people in London that aren't getting the social services or other support that they need. How are you going to make sure, with the funding challenges that have been raised, that you need to be properly funded, that if this particular service is not funded, or this taking back this responsibility from the police is not going to overextend your staff, because we end up back in the situation where, again, no NHS staff are going out, the police have gone, not my problem anymore, lots of people are left without support. That was to everybody, but if you just want to respond in the way that you want to.
We have a problem with the microphones, so if anyone in the broadcast team can actually help, but if you can use another one.
So like, we're in violent agreement about the need for really good funding for the services. One of the reasons I raised the issue of we would like to be funded for the extra investment we've put in to do this is because it feels really important that we get the funding. It's several £1 million worth of people that we have put in place to do this extra work. But the bit that I just want to gently push back on is the old response from the ambulance service to everybody was just send a double-crewed ambulance that often didn't actually even have a registered clinician on. The strategy that we produced last year for the next 5 years says that what the London Ambulance Service want to do is send the right response to each patient, and that in the main means get a specialist response to people with specialist needs. So we have been investing in putting mental health nurses with paramedics to go to mental health patients. We've been investing in putting community nurses with paramedics to go to frail elderly fallers. We're doing a huge piece of work with the Sickle Cell Society, and so that to ensure that our crews are all well trained in how to manage sickle cell crisis, because clearly that is a London-specific health need that doesn't get trained for in the normal paramedic curriculum. We're also doing a special piece of work for pregnant ladies from BME backgrounds, because they have special health needs. So we are doing our best to get a tailored and specialist response to different groups of patients. And it feels important to us that 10% of people who currently phone 999 have a mental health need. That's a huge number of people a day. So not only are we investing in mental health nurses, we've also got a whole training program for all of our paramedics to be upskilled in basic mental health, so that we can get it better, more right, more often for more people. So really, we don't want to offer a less good service to anybody. We want to offer the best service to everybody, and that does mean a tailored specialist response. That's what we're trying to invest in.
Okay, thank you. Do you want to go next, and we'll go around this way, please?
Thank you. Again, obviously, I think I set out at the beginning that we are chronically under-resourced, and that there's been long-standing discrimination against people with mental health problems. And I have to say, unfortunately, I think that's often an unconscious structural discrimination, and that's often, we've seen it played out in this room. I have to say that, as you know, Mr. Elkeles said, there has to be a recognition that people with mental health problems will need something different. And I actually applaud the fact that the ambulance service is investing in different types of vehicles and different types of approaches. However, it's absolutely crucial that there is a recognition that in London the population is extremely diverse. And that if you have taken soundings from people with lived experience across the country, then they will not be representative of people in London. And absolutely, in London, not only is the population diverse, but we have the highest rates of mental illness, not simply in the country, but in the world. And in places like South London, the rates of psychotic illnesses, for example, are 4 times higher than they are anywhere else in the world except for Trinidad. And unfortunately, a significant proportion of the people who are going to suffer mental health crisis are people from black populations and other ethnic minoritized populations. And that is because of the ongoing and long-standing structural discrimination. If you are going to put those people in vans that are beautiful in the inside and work very well, but unfortunately look like mental health vans on the outside because they're grey, as opposed to being like normal ambulance livery, then there is going to be a problem. So again, a strong plea to you, please, 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 do not do that. And we will support you in getting soundings from representative people who are going to need your services in London. And we would also really, really, really be very keen to work with you about how to support people with mental health problems in London to get the best care they need, not just when they're at the point of crisis, but also when people are in hospital, because there's lots of things about conveyancing, etc. We do need to have a longer term approach to how to resource mental health problems in London, because the formulas that exist, like Barnett formula, etc., for the whole of the country are unfortunately they're not fit for purpose anymore. And they don't really wait for the actual need that exists in London, because we know now that so many mental health problems are driven by social issues, housing issues, the wider social determinants, and there are just more of those problems in London.
Yeah, and just to reiterate Lade's point, and I do want the Assembly members to come away really understanding that we support our colleagues. First and foremost, we absolutely know the system beforehand wasn't working. I have personally sat in A&E with a police officer for 8 hours trying to get help. So there is no doubt that the direction of travel is one we all want to get to, and we must be getting people in the right places at the right time. So, but it is in the rollout that we really do need to think system-wide. And so, my plea is to really think about how we can deepen our collaboration, how we can really get ahead of some of these adverse events that we know are happening, without the data, if you like, that we have a plea to really iron out and thrash out the issues related to children, young people particularly, because that is a vulnerability that we are, fairly terrified of in terms of what the consequences could be. So I guess it is just to reiterate that point. We're totally alongside you, but we have to accept here that we're not really able to demonstrate at this moment in time the positive impact on the whole system, or indeed the idea that people are getting a better service.
If I may, Chair, at this time, I think in heated agreement with everything that's been said, and absolutely I welcome the discussion and feedback. I think the spirit of today's discussion is exactly where it should be. It's all about the people who are affected rather than anyone's demand. But the point about disproportionality must be mentioned as well. I think I absolutely agree. Disproportionality in use of police powers is a continued concern for many of our communities, particularly our black community. When you consider that in the setting of Section 136, it couldn't be more imperative that we do not ever over 136. You imagine the impact on hearts and minds in our black communities when they see someone who is suffering from severe mental health illness being bundled into a police van in handcuffs, because they think they're being arrested, when in fact we're actually detaining them for their own safety because we're trying to get them to health facilities where we can care for them. But of course the perception outside in is the police have arrested that person, they're taking him away, they're using force. And of course, sadly, that in those instances were what we were having to do. So this really is a quantum leap, hopefully, in our relationships with all of our communities, but particularly our black community, because every time we manage to divert, and Lynette, just before you came in, I was talking about the mapping we did at the mental health crisis cafes, and which Ali led on, just every time we can divert someone away from the Section 136 pathway towards a more caring and an expert pathway such as that, kindly provided by our colleagues here, or likewise through our ambulance service colleagues to a health-based place of safety or similar, that's a huge success for us as a society, isn't it? Because we're no longer using what are restrictive, coercive policing powers to serve something which is ultimately a health crisis for someone. So it really is impressively, massively important that we get that right from a policing perspective for our relationships with all our communities, but especially our black community, because if we're disproportionately detaining them when they're mentally unwell, that's always going to end badly. And that's then before you get to, of course, the risk to those individuals. Using force, as we sometimes have to, always comes with risk. And that no one, I know, carrying a warrant card wants to use force in that way against someone who's unwell. Equally, the risk to our officers in those situations when they then find themselves under investigation if something goes wrong because they've been stood in an emergency department for so long, trying their best for someone but unable to understand what's challenging them so badly. And then, of course, the risk to our wider communities when we as police service are not available to respond to the domestic abuse call or the burglar on a property or to police a demonstration because we are, as you say, doing something which in a better world we probably shouldn't be doing ourselves. So I didn't want to miss I don't want to make it sound like a Sermon on the Mount, but equally miss that opportunity to say that there is a very significant success here for us as a society if we can minimise our use of restrictive police powers in what is a really critical health situation. So, but welcome the support of everybody here today in how we do that together.
Thank you. DS, Vanna, and then Alison. I don't know if you want to add anything or go straight to Alison.
Thank you. Also in violent agreement with this conversation. And I think one thing that we have touched on briefly is health inequalities. And I'd really welcome a conversation about how we look at this work through a health inequalities lens. At LAS, we've just set up a new team whose core function is looking at health inequalities, and I would really welcome our input and members' input into that work and looking at both mental health provision, the provision of care to people under detention, through a health inequalities lens through that piece of work that we've just commissioned, and I think that would be a positive outcome of some of this discussion.
Okay. Thank you. Assembly Member Pigeon.
Yeah, I just want to pick up on the training really for officers and staff with the rollout of Right Care, Right Person. Wondering, do you feel the training has provided and equipped officers and staff with their roles, particularly the call handlers? And what are you doing to sort of monitor and quality control the responses that have taken place, particularly the call handlers? Are you doing some dip sampling? What are you doing to assure yourself that this process is working?
Yes, thank you very much. I think it's worth considering to start with, in terms of our call handlers, so we have 2,500, 3,000 call handlers across 3 sites. This was a significant cultural change for them in those decisions that they were making. And so what we had to start very, very early with those call handlers, talking to them around procedural changes, but also the legislation which they were not au fait with. Right. We then went into very in-depth training with them and developed subject matter experts within their teams as well. So each of those teams have 2 subject matter experts and also supervisors that oversee. On top of that, we have 24/7 floor walking capability. So persons who are on the floors with the call handlers who are there just to support them in terms of their decision making for Right Care, Right Person calls. So predominantly it was based around the call handlers, but also our frontline policing colleagues, those emergency response team and neighbourhood policing teams, had to understand it as well. So there's an online learning package for them. But for them, it was really to understand what was the principles and what were the call handlers doing, but also when they come across a health-related call in the street, so they're out on patrol and they come across someone in health crisis or mental health crisis, that nothing changes, that they deal with it in exactly the same way that they did before, and they do not walk on by. That's the input that they got.
Okay, but then how are you... That's the theoretical, and walking the floor, that's kind of live assurance, but actually your monitoring committee with Martin and others surely are wanting to look at pulling out some samples to have a look at that to see whether this is the theory, what's happening in practice. How are you assuring yourself?
So there is formal escalation processes. So when we went live, we were having twice daily calls with all partners who were able to listen in and raise any concerns that they had regarding specific calls or thematics that they were seeing. There is a formal escalation process where a partner could come in and say, we're not happy with this response. Our teams will listen to that call, feedback to both partners and to the call handler as well. In addition to that, you mentioned around dip sampling. So all teams, all supervisors are dip sampling those calls that are coming through as well. And they are hundreds of calls that are being dip sampled.
And presumably this piece of work, I can't remember the institute that's doing it, that Martin mentioned, will also be doing some of that sort of sampling to assure themselves as well.
Yeah, absolutely. And there is a Home Office review that is going into Right Care, Right Person as well. That's very much in its infancy, but the Met are one of, I think, 4 forces which are taking part in that review.
Lovely. Okay, thank you. Thank you, Chair. Sorry, Dr. Smith, sorry.
Just a very quick point on the training and understanding, and I think you did make the point that it may not be understood so well on the ground, and I do need to provide an example because it's really important that there's good understanding that there has to be much more attention paid to the impact on health services.
Yes.
So very recently, only a couple of weeks ago, I was contacted to say that a doctor was at work in their unit on the ward, patient with a mental health problem, actually grabbed the doctor and took a sharp implement and tried to stab the doctor in the neck. And they rescued to the ground. Luckily, the doctor was able to get the sharp implement away from them and could have been killed. This would be something that would be, obviously it was reported to the police. That person actually has neurodiversity. They could easily have been prosecuted, but then given a package of care that would actually help them to reduce the likelihood of them behaving violently as a result of their problems, which is what should have happened. In fact, the doctor, the reason I heard about it is because the doctor was told by the police, actually, because this happened with someone who's got a mental health problem, it's not a police matter. So there are some significant concerns that we have about the training and the understanding. And it's not good enough at the moment. I mean, that's the thing that has to be recognised. What's happening might seem successful, but it's not yet good enough. And we have to be sure it's good enough, because if we think it's good enough, then we won't do the work that needs to be done to ensure that it's going to be good enough. And my concern is that health professionals will be unfortunately disproportionately affected because they'll have much more work to do that they're not going to be able to cope with. That means that patients won't be looked after when they need to be. There'll be longer and longer waiting lists, and it also means there are going to be more safety issues.
That's interesting, because that's about the messaging. We don't do mental health now, and that might be something within the Met you might need to be thinking about, because that's clearly having an impact.
Absolutely, and anything we can do, and everyone's please join us in this to dispel that myth. We'd welcome, because there's absolutely no sense in the Metropolitan Police Service that we don't do mental health anymore. You know, there's a firm commitment, as I said before, everything from suicide intervention negotiations, right, and it's been acknowledged here today. You know, right down to Section 136 and 135, where both are necessary, and to our broader role in neighbourhoods. So please don't take away in any way anyone here today, I hope, or anywhere involved in this, that we're somehow not concerned or doing something about mental health. We have a very significant amount of resource still pointed at all things related to mental health, illness, and are committed to protecting our communities wherever they need us in any form of vulnerability. Okay. It's just, this has been quite a surgical approach to what has been quite a difficult situation around things like the overuse of Section 136. More broadly, as Martin rightly said, beyond mental health, serious concern for welfare, and a necessary recalibration of where we apply our restrictive powers and where we apply our precious resources, which, as this committee will know, are required on any number of other fronts, all of which we have to service. So It isn't anything ill-willed, and nor is the sentiment and discussion here today as well, I hasten to add. So it's good that we're having this discussion. It's just it needs to be balanced, doesn't it?
Lovely. Thank you, Chair.
Thank you. Assembly Member Ahmed.
Thank you, Chair. So my question is to the Met, and it's a technical question. So when a call comes in terms of determining whether this is a mental health crisis and whether it's actually a life-threatening situation, how do you do that? I mean, I think I'm even asking, what kind of questions do you ask? How is it a tick box exercise, or does it go beyond that?
Yes, so there is a toolkit that the call handlers use, and although it's not a tick box, because what we don't want to do is for call handlers to really get into the depth of the questions that they're asking. But absolutely right, if someone if there's a real and immediate threat to life or serious harm, then that is one of the first questions that is on the toolbox. And if that answer is yes, the likelihood is that police are deploying. And with other panel members have spoken about a cliff edge reduction. There is not a cliff edge reduction. It's a 14% reduction in our deployments to health-related calls. So as you can see, that we are where there is that real and immediate threat to life or serious harm and policing response is most appropriate, then we are still going. And that is in the vast majority of cases. And that is what the call handlers work through.
Okay, thank you, Chair.
Thank you. Assembly Member Devonish.
Thank you very much, Chair. I think two of my questions have been answered in a very good debate this morning, so I'll be brief, and please don't feel you need to say what you've already said before. So my question is to NHS England, LAS, Mind, etc. Right care, right person sets out to, I quote, end the inappropriate and unavoidable involvement of police in responding to mental health needs, unquote. What noticeable differences are there in the care being delivered to those with mental health issues in London, please? I think it's pretty much been answered, but I just thought I was asked to read it out, so I will. So the second bit of that is...
I'm sorry, can I say something? That's not really a question for the Met or the London Ambulance Service. That's a question for the Health Service, isn't it?
I did.
But I just wanted to say that it's really important to say that we don't know for sure, but we have had a lot of concerns raised by mental health practitioners about what's going on the ground, and they're worried that they are unable to see people as quickly, and that they're unable to get police response for very legitimate and necessary interventions. And this isn't simply when people are in crisis.
No, understood. Chair, I think reading the rest of it, I think it's pretty much answered, so I'll move back to you. Thank you.
Thank you very much. And so I just want, it's been an amazing conversation. It's been really, really helpful to have all these voices in the room. And you've given us an awful lot to think about, and I'm kind of drafting a letter in my head of some things that we'll raise and send back to everyone in terms of the things that need to be thought about and developed. I think the point about reducing the use of force, that is very welcome, because many of us have had all sorts of pieces of casework where Londoners have had bad interactions with the Met in terms of use of force, and particularly around mental health crisis and also neurodiversity. So the fact that you are doing so much thinking about all of this is definitely very welcome, and really welcome all the sort of commitments to ongoing dialogue, because it does seem that sort of partnership and dialogue is, everyone is stretched and everyone is dealing with years of budgets getting tighter and tighter. And so that dialogue piece just feels as if it's absolutely critical. I just wanted to finally check what the key indicators are that are being used to measure the success of right care, right person. And that's both within the Met and within the ambulance service, and also whether Lade or either of you from Mind have are kind of doing any measurement of what you're seeing of it. So should we start with the Met?
Thank you, Chair. And for us, it is much of what we discussed today. It is numbers of Section 136 detentions that are effective.
Yep.
It's also the number of incidents that we experience involving mental health crisis and the number of times we deploy to those, because that's a far greater figure than just Section 136. And indeed, serious concern for welfare calls as well. And of course, other colleagues track their own data, which we then share and share alike as well. So, Ali, did you want to add any more from...
No, I think it's just from... We've spoken about before about people falling through the gaps. What we actually think with Right Care, Right Person, before Right Care, Right Person, sometimes you could have a situation where organisations weren't sure who was taking primacy for those calls. Under Right Care, Right Person, because the police make a decision and we transfer that call through to the London Ambulance Service for their health triage, what we say is there is no gap, because that person is transferred from one organisation to the other. So that's the other metric that we obviously measure, which is then picked up by the London Ambulance Service.
Thank you. And then from the London Ambulance Service perspective, what are you measuring and tracking in terms of this rollout?
So our data is also being collated as part of the NHSE group. Some of that's been covered already. So we are looking at overall volumes of calls that are coming to us, both directly from the Met Police, but also directly from other members of the public who are quoting Right Care, Right Person and those types of calls. Importantly for me, from a safety perspective, we're also able to track recontacts, so patients who have contacted us more than once, and the outcomes of those contacts. And from a safety perspective, I think that's really, really important. We're also monitoring our onward care provision. So when we do attend our patients, what is the decision making? So are we taking those patients to an emergency department? Are we referring them into a community provider, into a mental health team in the community? Are we taking a patient to a crisis cafe? So we're able to now monitor that quite closely. And then I mentioned earlier our health inequalities work, and through the initial work that we've done about health inequalities, we're able to measure our demand broken down by hour of day, by day of week, by area across the whole of London. And within that, what are our patients calling us for? What's their primary concern when they call 999? But importantly for me, we're also able to look at the age of the patient, the gender of the patient, the race. So a whole heap of really valuable data that we're now capturing that I think can help develop this piece of work moving forward.
And is that data being interrogated, for instance, to look for disproportionality in outcomes?
So through the data subgroup of the NHSE board, yes, absolutely. And moving forward through the health inequalities lens, we will definitely be doing that. The other thing that just sprung to mind, I can't remember who it was, mentioned preventing future deaths. And so ambulance services across the country bring together their knowledge and input when an ambulance service, or in fact all ambulance services, receive a prevention of future deaths notice. We have a process where we share that information and we learn from each other's incidents as well. And I think that's going to be key moving forward also.
Thank you. Yes.
So just to put Alison's, all of that is totally right, and I just put it in the macro of our mission is to be the capital's urgent and emergency care responders. And what we're talking about is getting the right response to a really quite a diverse group of people who either have urgent or emergency care needs. And that's the lens we're looking at it from, is are we giving a good response to the capital's urgent and emergency care needs? And the last little bit is, on these mental health ambulances, we will go and take some soundings from how the livery was designed, but if the right answer is they should have the yellow and green Battenberg livery to look like any of the other emergency vehicles we have, we will do that.
Thank you.
Thank you.
Laddie.
As we know, unfortunately, the NHS has been a bit on the back foot in terms of collecting the metrics, but the kind of metrics that we think are important are not necessarily simply the front door metrics. And obviously, we collect those anyway, you know, who's coming in. We look at the demographics of our patients because we've had long-standing issues with disparities according to race and gender, etc. But the things that we are now starting to recognise, and this is from the reports that we've had from people's experience, are staff diversion from their usual work. And that's staff in inpatient units, as I described before, but also staff waiting times for mental health act assessments. So when a mental health act assessment is deemed necessary, there'll be a risk assessment. Sometimes it's recognised that there has to be police involvement. We ask the police, and the police will give a time when they can come. What people are finding is that the police are extremely stretched. And so it's been, the time for that has been delayed anyway. And the concerns are that the delay is actually getting worse. The time for waiting for a Section 136 assessment, again, that's a 135 assessment, sorry. Again, that's a type of mental health act assessment. We're also obviously looking at any particularly police response to patient assaults, patient incidents, most assaults in inpatient units are patient against patient. There are some patients against staff. And so we're also looking at the police response to those. And also, of course, we are looking at, and these will be few and far between, hopefully, any very serious incidents that occur as a result. That, for example, we find out from the coronial process that there has been a question mark about right care, right person being involved too.
Thank you. And Dr. Hughes, did you want to add?
Just finally agree with all of that, and I think that there is something about remembering that data comes in lots of forms, and so we want the hardcore, you know, kind of qualitative and quantitative data. And again, you know, people with lived experience telling that story about what it's been like, also listening to agencies, that will be incredibly important. But I do want to reiterate some of the concern that's already been mentioned around the table about the fact that local authority isn't here, and we cannot underestimate the importance of local authority. And I might say that sadly, and this I think is probably reflective of their own situation, but it's very difficult to get them around any table to talk about mental health, particularly. So this isn't directly in relation to RCRP, but is an important point. We need to get them around the table.
Thank you. Thank you. Lynette, did you want to add anything
just
finally?
Quickly, and that is that in London we meet regularly and we are looking at the impact of right care, right person, really listening out for the stories that might come from the local minds that serve London. In our ICB area, this is already on the agenda. We're trying to see the effects that it's having across Barnet, Enfield, Haringey, Camden and Islington. So I think alongside our colleagues here, it's really about getting a full picture, not just from one person's point of view about whether this is successful or not. And we're more than happy to share that, and we feed up to our Mind colleagues so that we can get a picture across the country.
Thank you. I mean, I think what's been really extraordinary about this morning, and I sort of hands up, none of us thought at the scoping stage of this about adding local authority attendance, although it would have then been a very, very big panel and even harder to make sure everyone was heard. So, but we've definitely taken that point on board. But I think what has come through so strongly is that all of you, from all of the places you're from, are really thinking and caring about what you're trying to do, and the other piece that has come about is the importance of everyone continuing to talk to each other. And I think that's my biggest takeaway from this morning. But I just want to thank all of you for your time and the care that you've put into your answers, because we've all learnt a huge amount. And I suspect the committee is going to keep looking at this into the new term after the election. So I would now formally like to thank our guests for attending this morning and for your answers to our questions. Can I ask the committee to note the report and the discussion? Can we also delegate authority to me as chair in consultation with party group leaders to agree any output arising from the meeting? Can I ask the committee to note the work programme for the 23-24 Assembly year? The rest of. And the next meeting of the committee is scheduled to take place on Wednesday, the 21st of February at 10 o'clock in the chamber here at City Hall. I have no urgent business, so that concludes today's meeting.
This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.